it was probably 3 months into my internship, and I had memorized all of my little protocol cards. We kept them tightly with us in our pockets. And what do we do if we have a bradycardia? What do we do with asystole? What do we do? And every intern and every resident knows that they're going to get called upon to participate in a code blue. And when it happened, I ran out of the room that I was in, and I started running down the hall along with a whole bunch of other residents, and we were being directed down by, orderlies, and there were nurses telling us which way to go, like an airplane coming into a berth. And I was thinking about who was going to be in that room that I could help. Was it going to be a 50-year-old man with a heart attack? Would it be a woman, a pregnant woman who was having an asthma attack? And when I entered the room, it was just pure shock, because what I saw on the bed was a body. And that body was yellowed and had clearly been sick for a long time, and had really just was frail and what we call cachectic. There was no muscle or fat on the body at all. And a co-resident was already on the bed doing chest compressions on the body, and I could hear the chest cracking and breaking, and it was gruesome. And then I got pulled into it, and I remember just feeling horror. And about 27 minutes into it, someone said to the resident who was running it, can we call this code now? And the resident said, you know what, let's give it another 3 minutes and just make it an even 30. And it just felt like I was on an assembly line.
At a certain point, you became a convert to a new way of looking at care, at least for a certain segment of patients in the ICU. And like most converts, you had an epiphany. So bring us to that epiphany. It's 10 years later. You're at University Hospital in Newark, New Jersey, still and practicing critical care medicine. What happened there?
So I was working at this hospital in the center of Newark, a pretty safety net hospital. And unbeknownst to me, and to my tremendous luck and benefit, it was one of 4 hospitals out of 422 applications that had won a grant from the Robert Wood Johnson Foundation to try to increase communication in the intensive care unit, to try to enhance information transfer to patients and families. And there were these people who would kind of come in to the ICU. There were some nurses and some counselors, and led by this woman named Pat Murphy, who's an advanced practice nurse with palliative care training. Palliative care didn't yet exist. It was 2003. Didn't really become a subspecialty in 2008, until 2008. And Pat would come in and frequently criticize things that we were doing. And she would say, what are you doing to this patient? This is crazy. And I would roll my eyes and think, who is this woman? And one day, I was asked to put in what's called a Quinton catheter, a very large catheter for dialysis into a patient. She had stage 4 breast cancer and was very, very close to death. And they wanted to do dialysis because her kidneys had started to fail. So I went and I got consent from the husband who was sitting in the waiting room, and I made sure that her blood coagulation parameters were normal, and I got the whole room sort of sterilely covered in blue drapes, and got my medical student sitting next to me. The kit was all set up, and the nurse was ready as soon as I got the line in to connect it up. And I looked up and I saw Pat standing in the doorway, and she was just looking at me with this look of disgust. And she went like this. She put her phone up, her hand up like she was holding a phone, and she said, 911, call the police. They're torturing a patient in the ICU at University Hospital.
Wow. Now, when I talk about this to other people, and as you know, you and I both do frequently, one of the things that comes up is people say, well, okay, I know that if I'm in a certain position, it's a pretty long shot that I would actually be able to be rescued or saved, or even just live for a couple more years at decent quality of life. But why not play the lottery? I mean, this is my life. I mean, I buy a lottery ticket, and I don't expect to win, but if I do, it's great. There's a lottery analogy you work with this.
I totally understand it. I can completely understand when we're dealing with life and losing someone, losing a loved one, and most of the time I'm dealing with family members, not the patient, him or herself. And this feeling of just take a chance, or maybe God will work a miracle, or who am I to take away any potential chance? What I think sometimes people aren't considering is the other side of those odds. When you buy a lottery ticket, you have a tiny, tiny chance of winning. But if you don't win, you just have lost a few bucks. In this environment, you have, again, in situations where doctors are telling you we think things are not looking good, you have a tiny, tiny chance of recovering to a place that would probably be acceptable to you. I don't know how tiny. Obviously, it's different from case to case. But in many of the cases I'm talking about, it's very small, if not impossible. And people still say, I'm going to take that chance, but they're not thinking about the other sides of the odds, which are not losing a few bucks, but being committed to a suffering and grisly death.
So that's where the analogy breaks down.
It breaks down.
Yeah.
Terrible case many, many years ago of a man who I took care of as the ICU attending, who had come in from a nursing home where he was living on a breathing machine with a feeding tube, and he'd been there for, I'd say, 12 or 13 months, and he'd been admitted in and out of the ICU with septic shock, with urinary tract infection or pneumonia or some kind of a skin infection, and we'd treat him, and then we'd send him back to the nursing home. And when I met him for the first time, it was, I don't know, his 8th or 9th admission, and when I saw him, I gasped, because his body had broken down so much that you could actually see his hip socket. I've never seen that before. And it was I will never forget it. And I thought, oh my goodness. And every time they would do a change to his dressing, his eyes would just, he was in terrible pain. He couldn't communicate with us. He had no family members. And what he did have was an advance directive that he had filled out 10 years prior that said, do everything, keep my body alive at every possible, and in addition to that, which was what was most notable, was a piece of paper that had been folded over many, many times that was stapled twice to this advance directive, handwritten in his hand about 10 years earlier. To any doctor that ever will take care of me in the future, I am asking you to prolong my life at all possible costs. And so it was a real, for me, an ethical conundrum, because I couldn't imagine that this man would possibly have known what this was going to look like. There's no way to know it, because we don't give people graphic visuals. We don't even tell people graphically what it will look like if they make that choice, what it's very possibly going to look like. And I don't think he could have known. My friend called me and said, I need your help. My friend is really in a terrible place. And I had known about this friend. He had been diagnosed with pancreatic cancer several months earlier, and had been talking with my friend about suggestions and recommendations for him. And he said he's really just in a terrible state. Would you talk to his wife? And so he patched me into a 3-way phone call while we were driving along the Long Island Expressway. And she was in a panic. He was delirious. He was incontinent. He was in terrible, terrible pain. And she didn't know what to do. She said, we've got to get him to his chemotherapy appointment tomorrow in New York, and I don't know how we're going to do it. And I said, oh my goodness, it sounds like he's not in any shape for chemotherapy tomorrow. Have you, started to talk to anybody about other types of approaches to his health care? And she was in a panic, and we ended up going there. I ended up going to her house. And he was in a very bad state. And I got more history from her, and it turned out he'd really, really been bedridden now for days, was really, really ill, had been delirious. I mean, this was a man whose body was shutting down. He was dying. And I said to her, listen, I really think that going in and getting more chemotherapy is not the answer. I think we should be starting to focus on his symptoms and trying to improve them and give him some comfort. And she said, oh no, he would never, he made me promise that we would do everything to keep him alive, and I would be letting him down. And I said, well, let's call this oncologist. And she had called this oncologist part of her A team. She had collected, they were a very smart, effective family, and she had collected an A team at this very high-powered cancer treatment center in New York City. And so I said, let me call this oncologist and tell him and describe to him, doctor to doctor, what your husband looks like, and we can come up together with a plan that makes sense. And she said, but I'm afraid he's going to feel like we're giving up. And I got him on the phone, and we were on speakerphone. And I said to him, look, this is what's happening. And he said, well, he started talking a lot of medicalese. Well, I'm not sure, is this biliary obstruction or is this? And I said, listen, I understand, I know this is a question, but he's really suffering right now. Do you think that hospice would be an appropriate option for him? And he said, look, if they want to choose hospice, that's up to them. almost as if, that's giving up. I mean, there was really that tone, and you could see the wife looked like, a little like she was about to be abandoned by her doctor, and she felt very anxious. And I said, okay, how about if we think about a middle ground where we enroll him in hospice, and if he starts to get better, and at that point the doctor said, well, that's not going to happen. I mean, it's funny now thinking back, but it was horrible to see the face on this woman when she realized that she had been looking to this doctor to care for her husband, and in fact, all she was getting was treatment. And and we ended up bringing hospice in that evening, and he ended up dying 2 days later in his bed, listening to opera music with his wife lying next to him. So we, hopefully we rescued him off of the end of life conveyor belt, but it was a close one.
So I guess the question I have is, why don't doctors in general practice more patient-centered, honest end-of-life care? What are the barriers?
Pretty much everything. I mean, it takes a huge amount of time. I don't know if I can possibly describe to you how much time it takes to sit down and have conversations of this nature and of this magnitude with people who are sick and dying. It's devastating and heartbreaking, and there's a lot of responses that you don't know if someone's going to get angry or start yelling at you or just be tremendously disappointed in you, and you're also feeling as a physician like you failed, which is a big part of it. If you can't make somebody better, which is part of our culture. And we don't get paid to do it. So, I mean, I don't personally care. I mean, that's part of my philosophy, but it's not fair to ask a physician to go and have a 1 hour, maybe 2 hour conversation with somebody that may go any which way and you don't know, without actually paying them for it. We pay for all the other procedures that we do without hesitation. But to do this one most, in my opinion, critical piece of work is not compensated. There is some movement. Medicare is considering doing that in 2016, thank goodness. But that's something that's way, way too late in the coming. So, I think that's very important. It goes, again, the other important thing to remember is, if you don't offer treatment and you say, here's another option, here's another way to go. In my experience, there will often be another doctor who will come in and offer it. And so you look like the naysayer, you look like the bad guy, you look like the pessimist. And that's a hard thing to put on somebody. And we can get around those things sometimes by trying to coordinate with the other physicians and really have a team approach to it. And that really is important. But it's a tough environment. We get all of these hours and hours of practice with the bronchoscope and with the protocols for Code Blue, but we get very little training on how to talk to patients as doctors. And that's really hopefully changing, and hopefully that's spreading with the work of the palliative care movement that's coming, a very recent movement since 2008, and I think that's exciting, but most young trainees report still that they don't get adequate training in how to talk to patients and break bad news and help people with rules of care. I think the data is so clear about palliative care that it is so clearly improves quality of life, quality of death, and it saves money. It's a no-brainer. I mean, there's a study after study after study after study. So it's good for the patients. It's sort of that perfect storm. And so I think most health insurance companies are starting to understand that it's good for everybody. And are supporting it. And I've watched that growth. When we started Vital Decisions, it was interesting. There were a couple of brave health insurance companies, this was in 2004, who said, okay, we'll do it. But they were really worried about being considered a death panel. And that seems to have given way to people just being more willing to health plans being more willing to embrace the concept of palliative care and support it. And I'm seeing it grow in front of my eyes. I mean, there's so much that hospice nurses and doctors do for patients that they will never get in any other environment. It's this intense focus on the family, on the bereavement process, on the acceptance process, on any kind of symptom that you could ever imagine. There's no ICU doctor can manage nausea the way a hospice nurse can. Pain management, sort of, so that you can maximize alertness and these are things that hospice people know how to do much more than anybody else. So for me, it's so easy to sell hospice because it's so great for the right people, not for everybody, obviously, but for people whose goals are to do management of their symptoms, to live as long as they can, but with a real primary focus on managing their quality of life and their symptoms. It's an easy sell, I think.
Good. We're going to have to leave it at that, given our timing. So I would like to thank Dr. Jessica Newdick-Zitter for her comments today. I'm Mark Zitter, and now this meeting of the Commonwealth Club of California, commemorating its 113th year of enlightened discussion, is adjourned.